Absolutely. Oaks, Derby, and Gale are the largest open label extension and longest clinical programs in geographic atrophy. As you will recall, patients with geographic atrophy secondary to age-related macular degeneration were randomized to receive pegcetacoplan monthly, pegcetacoplan every other month, or sham monthly or sham every other month in Oaks and Derby. At the end of 24 months, patients were eligible to cross over into GALE, the open label extension program, and those patients on pegcetacoplan continued on the same regimen, whereas those patients on sham crossed over to active treatment at the same interval. The efficacy endpoints included change in GA lesion growth and also safety endpoints. The disposition of GALE was fantastic at 36 months, with 67% of patients retained in GALE. Keeping in mind that this is an elderly population during COVID, there certainly were deaths not related to pegcetacoplan, and that, if you exclude those deaths, resulted in a 74% retention rate. In the overall population, we saw 19 and 18% reduction in GA growth in the monthly and every other month group compared to sham. In the subsequent 36 months of GALE, months 24 to 60, 27 and 26% reduction compared to sham, projected sham in the monthly and every other month group. It's important to note that the projected sham here is developed via statistically rigorous design and is developed via a literature-based approach using work from Janice Siness and others on predicting GA lesion growth based on the assumption that GA lesion growth is growing in a linear fashion, and finally validated by looking at the fellow eyes, which also grow at almost an identical rate as the projected sham. Next, I report the impact of pegcetacoplan in the non-subfoveal population. This, of course, is the lesions that grow the most rapidly and have the greatest benefit from pegcetacoplan. And we see that months 0 to 24 in Oaks and Derby, there was a 27 and 24% reduction in the monthly and every other month compared to sham. And the subsequent 36 months of GALE, we saw 33 and 30% reductions compared to the projected sham in the monthly and the every other month group. So overall, over the course of 6 months, we see 31 and 27% reductions compared to projected sham in the monthly and every other month group. Beyond lesion growth reduction, we can also look at tissue preservation in these patients, and we see that patients have tissue that is preserved. In fact, by the end of 60 months in the monthly group, we saw 3.9 millimeters squared preserved tissue. That's just over 1.5 disc areas. We also see that those patients who began pegcetacoplan from the beginning of the trial actually had a greater amount of tissue preservation, almost 2 times more, 3.9 millimeters squared compared to 1.9 millimeters squared in that population that was in the sham crossover. Finally, the concept of time saved when it comes to disease progression is another message that we were able, or another valuable lesson learned from 60 months of data here. We see that at the end of 60 months, pegcetacoplan treatment saved about 1.5 years of disease progression compared to those patients in the projected sham. The safety, of course, is of paramount importance, and we see that the safety profile in GALE is consistent with Oaks and Derby, including the rate of infectious endophthalmitis remaining consistent at 0.04%. The IOI rate was 0.24%, with all episodes being mild to moderate, and those episodes that required treatment were treated with just topical medications and resolved. The ION rate was 0.02%. So overall, the results from GALE were encouraging, and we see continued benefit for our patients. Yeah, this is a great point and a great finding from the data here. Time saved or time preserved really resonates with patients. So a patient after 60 months of treatment can expect to be where a patient in the sham group would have been at 1.5 years earlier in terms of their GA lesion growth. And so this certainly resonates with patients, that you're saving time for them, time with usable vision, hopefully. So in the overall group at 5 years, from month 0 to 60, we saw a 24 and 23% reduction in the monthly and every other month. So very similar numbers in the overall population that included both non-subfoveal and subfoveal patients. If we look specifically at those non-subfoveal patients, however, we see that the difference is also small, 31% reduction in the monthly group compared to 27%. So just a slight difference between the monthly and the every other month group, approximately 4%. The long-term data is very encouraging. In fact, we see that we have increasing amounts of tissue that is preserved year over year for patients, and also saving patients on time. And so I think that the difference between monthly and every other month dosing is reasonable, and certainly it tends to shift me more towards every other month dosing, which helps the patient with the injection burden, and certainly also helps mitigate some of the safety issues that are dose dependent. The safety profile in Gales remained consistent with Oaks and Derby, and we see low rates of intraocular inflammation, 0.24%. In the trial, this inflammation was mild to moderate, and in fact, just about half of the patients required topical treatment only, and resolved. And so, the rates of post-marketing vasculitis have remained consistent at 1 per 4,000, and this is predominantly a first injection phenomena. We've also seen that this rate is about 1 in 11,000 for severe vision loss, which is 6 lines or worse in terms of vision. It seems like the rates may be dropping actually when you look at year over year, 2023, 24, or 25. The rates of post-marketing vasculitis that have been reported have dropped from 19 to 11 to 2 episodes only in 2025. We're not sure why this is, but the fact that the rates are consistent or potentially dropping is encouraging to see.